Thank you for joining us for this MDA Engage community webinar on Facioscapulohumeral muscular dystrophy, which is a genetic disorder in which muscles of the face, shoulder blades, and upper arms are most affected. My name is Kristen Brunk, and I'm a care specialist at MDA. We are thrilled to have you join us today for this important and educational webinar. I also want to thank all of our supporters at Fulcrum Therapeutics, as their support is greatly appreciated. The webinar today is part of our larger MDA Engage flagship community event series, which focuses on bringing in the neuromuscular disease community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual educational events. We are recording today's event and will be posting it to the mda.org website for on-demand viewing to ensure that those who are not able to join us live today are able to access this information. Please know that all phone lines have been muted. We will be having a question and answer session towards the end of the webinar. Please be sure to utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A bubble to open the window and enter your question. You do not need to wait until the Q&A session to chat in your question. As questions come up along the webinar, please feel free to send those in. Before we begin, I'd like to say thank you to our speaker, Dr. Johanna Hamel, whom you will meet shortly. Let's review the objectives for today's webinar. Attendees will briefly review facioscapulohumeral muscular dystrophy, discuss best practices in clinical care for individuals with FSHD, and learn about current and upcoming research in FSHD. Now I would like to introduce our speaker, Dr. Johanna Hamel. Dr. Hamel is a neuromuscular specialist and assistant professor of neurology, pathology, and laboratory medicine at the University of Rochester, New York. She cares for patients with neuromuscular diseases with a focus on myotonic dystrophy and facioscapulohumeral muscular dystrophy in clinic, and conducts clinical research with the overarching goal to find and test therapies for people with muscular dystrophy. Her research focuses on ways to measure disease severity and progression of muscular dystrophy and to better understand the underlying disease mechanisms. Thank you so much for joining us today, Dr. Hamel. We are so excited to hear from you and are very grateful for your participation in this event. And with that, I will hand it over to you.
Thank you, Kristen, for your kind introduction, and I will share my screen here in a second. Oops. All right, you should all see my main screen now. All right, yeah, thank you so much for having me. I'm excited to speak today, and ideally I would see you all in person, but we'll do the best we can with this program. But so starting with, let me just move, sorry, I'm just moving a window here. Okay, and then I'm adding a little laser pointer. Okay, perfect. So what I want to focus on today is I want to focus on what's the root cause of FSHD. What is the mechanism of the disease, and how do we understand it best? And the reason why I bring this up, and I want to discuss that up front and really spend a little bit of time going through it, is because with emerging treatments now and in the future that target the disease mechanism, it will be important to understand where in the disease mechanism, what is this drug targeting, and how does actually the muscle disease occur in the muscle, and where does the drug target it, and what is the result, what are the risks. And for all of that, to understand what these trials are about and what the risks are, I think it's important to understand the genetics, and that's why we'll spend a little bit of time on that topic. And then we'll talk about what symptoms do people with FSHD experience, and you are the expert on that, so I'll summarize what we've learned from you and what interventions and treatments are available as of now in the clinic. And then we'll close on talking a little bit about research and where to connect best, if you're interested in that. And just as a disclosure, you may have heard talks on FSHD, and this will all be old to you and just a reminder, and for some of you it will be new. So let's get started. And again, I'll start with what is the root cause of FSHD. Now, as you know, FSHD is caused by a variation in genetic material that causes the disease. And usually we call variants of genetic material that are disease causing, we call them mutation. And sometimes the diagnosis is made just by your clinician in the clinic based on symptoms, based on the physical exam, and based on a family history, like other family members that are affected. However, oftentimes we try to be more definitive and confirm a clinical diagnosis with genetic confirmation, which means obtaining a blood test to see if that individual has the genetic mutation that causes FSHD. And if you had genetic testing, you may have received a report that can look like this here. For example, impression 4q35 deletion consistent with Facioscapulohumeral muscular dystrophy type 1, FSHD1, see comment. And then there's a blurb down here. And so, but what does that mean? And it says FSHD1. Does it mean there is more than one type? And why does this mutation cause FSHD? And that we will try to answer a little bit in this talk. To better understand this, let's take a step back and we will review some basic genetics. As you know, we're all made out of genes that contain information about things like hair color, eye color, or other features. And these genes are made out of DNA, and DNA sits on these small molecules that look like exons or chromosomes. And those genes carry instructions how to form proteins that we're made of and that are important to live. And everyone has 22 pairs of chromosomes, one that's passed on by the mother and one that's passed on by the father. Not only things like hair color and eye color are obviously passed on by a parent to a child, but also genetic information that can cause problems, such as an FSHD, such as a genetic mutation. And in FSHD, the genetic mutation is located on chromosome 4. Now, there are different ways how a genetic mutation can occur and how it can be passed on. Sometimes the mutation just happens within one person within a lifetime, and we call this de novo, which really means sort of new from scratch. And that can also happen in FSHD. And for example, there may not be any other family members affected, but just one person. But in most people with FSHD, the mutation is inherited from a parent. And in FSHD, we call this pattern of inheritance autosomal dominant. Now, what does that mean? So everyone receives one copy of a gene from the mother and one copy of the gene from the father. So here you see a person in transparent that does not have FSHD and has two healthy copies of the FSHD gene. So the child has a risk of, or not a risk, but has a chance to get 100% chance to get a healthy copy from that non-affected parent. Now here's a person with FSHD, and to have FSHD, you only need one abnormal copy. So one abnormal copy of the gene causes the disease. So this person with FSHD has one normal copy and one abnormal copy. So the risk for the child to inherit the abnormal copy, so the FSHD gene, the mutation, is 50-50. And each child has a 50-50 chance to get that abnormal copy, to get the FSHD gene. And that risk is each time the same. And even though I don't like the metaphor, but it's like flipping a coin each time, it's 50-50. But now let's take a closer look at what I mean when I speak of a mutation in FSHD. So here we zoom in on the chromosome 4, and we look at a section that makes up a gene and that contains of DNA. So at the FSHD locus on chromosome 4, there is a repetitive sequence of DNA, and we call these repetitive sequences repeats. And each repeat contains the DUX4 gene. And DUX4 will come up a lot, and you may have heard all about it already. But the DUX4 gene is really the disease-causing gene in FSHD. And the DUX4 gene is normally silenced. So in individuals that do not have FSHD, this gene is silenced. It's nicely tucked in and folded up and doesn't do anything. It's not transcribed into RNA. It's not the protein isn't built, it's just silenced. And you wonder, why is it there in the first place? Well, it has some role in development early on when life develops, but in further, in further life, it's just not of any use, so it's tucked in and silenced. However, in FSHD, the opposite is the case, and actually DUX4 is expressed and active and transcribed into RNA and made into DUX4 protein. And DUX4 protein is the problem in FSHD and causes muscle disease. Now you wonder, how does this happen? How, from the mutation to the protein, how does this happen that the gene that's supposed to be silenced is active and causing trouble? Now there are two ways how this can happen, and these two ways are called FSHD1 and FSHD2. And we will talk about FSHD1 first and then about FSH2. But basically, people without FSHD have more than 10 of these repeats that contain the DUX4 gene. That's normal. And again, here you see you have 2 copies of the gene, one from mom and one from dad. Now, in people without FSHD, when you have more than 10 repeats, the DNA with those repeats is nicely methylated. And methylation is sort of a coding with methyl groups that really nicely code the sequence. And in FSHD1, in contrast, here's the normal allele, so that's the normal copy of the gene. And then here on the bottom, you see the abnormal copy that is disease-causing. And what do you notice here in red? Well, the number of the repeats containing those DUX4 genes is reduced. And in FSHD1, the number of repeats is less or equal 10. And the range of repeat is 1 to 10. So people can have 1 to 10 repeats, something in between there. Now, as a result, because there are a reduced number of repeats, the DNA sequence here is what we call hypomethylated, meaning that the molecular coding of that molecular methyl group in that region is inadequate and reduced. This type of problem is present in most of the people with FSHD. So FSHD1 makes up 95% of people with FSHD. Now you wonder, what about the other 5%? How does that create a problem on the gene? We'll talk about it here. And the remaining 5% of people who have FSHD, again, they have a normal copy of the gene from mom or dad, and then they have an abnormal copy of the gene. What do you notice here? That actually looks quite normal because people with FSHD2 have a normal number of the repeats, so not reduced. However, usually the number of the repeats is in the low normal range, so between 11 and 20, for example. Now you will say, well, that by itself doesn't cause FSHD. That's true, but in addition, in FSHD2, there's another mutation on a different gene located on a different chromosome that contributes to the problem. And in most people with FSHD2, that is involving the SMCHD1 gene, what's located on the chromosome 18. And a mutation in that gene causes abnormal methylation of that region. It causes reduced methylation, or what we call hypomethylation. So it reduces the coding, the methyl coding in that region. But now you would say, but how does this cause disease? We're still not there. You know, the DUX4 protein isn't quite, we haven't talked about that yet. True. So what happens is that the methylation is important to kind of tuck away the gene. So for example, here, normally the gene is nicely methylated and the gene is tightly packed, and you can think about it like a slinky. It's really kind of tightly packed and hidden there. However, as discussed in FSHD1 and FSHD2, this coding, this methyl coding isn't adequate. And so what happens is that this chromatin frame opens up and the DUX4 gene that sits on those repeats is transcribed into RNA and then made into DUX4 protein. So, and then the DUX4 protein in the muscle causes FSHD and the disease. Now again, The hypomethylation, the reduced coding of the gene region, causes opening of the gene structure, and then DUX4 that's supposed to be silenced and pretty much tucked away in normal in people without FSHD gets transcribed, gets activated, and transformed into protein that then causes muscle problems in FSHD. So to summarize this complex mechanism, DUX4 is really the root cause of disease in muscle and FSHD. FSHD1, which is really the problem in 95% of people with FSHD, involves a reduced number of repeats on the chromosome 4, and that results in reduced methyl coating or reduced methylation of that gene region. And in FSHD2, there's a different mechanism how that causes hypomethylation, and that's a mutation on a different gene, on a different chromosome that causes reduced methylation of the repeats on chromosome 4, and then expression of DUX4. Now let's shift gears and talk about symptoms and how to manage them. So what symptoms do people with FSHD experience, and what interventions and treatments are available? Now, here a few facts up front. You may wonder, how common is FSHD? Well, we don't actually know because no one has really done a screening and evaluated how many people in the US carry the mutation or have mild symptoms or more symptoms. That hasn't been done, but we have clinic estimates or estimates from other countries or studies. And for example, in the Netherlands, it was determined that it's about 1 in 8,000 people have FSHD. But we don't know exactly, and it's also possible that people get missed or misdiagnosed, or specifically if people have milder symptoms, may never get diagnosed. So that's still a question. As another disclosure, I would like to point out that there's such great variability in how people experience this disease. So you may hear what I say and think, this doesn't really apply to me, or this doesn't really apply to me. And that's because there's so much variability in what symptoms people have, but also at what time in life people develop symptoms or are affected. And basically, symptoms can occur at any age, from birth to older age, but most commonly, on average, symptoms occur in the early 20s. And what is kind of disturbing is that people live for a long time with symptoms before they receive the proper diagnosis. And when we looked at our registry data, people reported that on average, they had what we call a diagnostic delay. So living with symptoms without a proper diagnosis is up to 13 years. And that's a problem, because if there are treatments that really make a change, we might want to intervene earlier. And so that's something to work on. Symptoms are variable, as I mentioned. Symptoms can be asymmetric, and specifically earlier on, the disease progression is also variable, and life expectancy is typically unaffected. Now, a few years ago, we asked people with FSHD what symptoms they experience and how much these symptoms impact their lives. And here's a list of the common symptoms on the left, so in descending order. And on the right, there is a list of symptoms and how they impact people's lives. So for example, if someone was impacted greatly, they would answer a 4. And if someone said, that's minimally affecting my life, they would have answered with a 1. And here you see the averages across all people. And so, yeah, so the higher score, the more it impacts people's lives. And what I would want to point out here is that problems with shoulders and arms was not only the most commonly experienced symptom, but also the one that impacted people's lives the most. And the 5 most commonly reported symptoms were also the 5 symptoms that had the greatest impact on people's lives. And note that mobility and walking is top 2 here, ranked 2. So that just indicates that while it's, you know, it's quite present, but it's still, has such a great impact on people's lives, and probably linked to independence and linked with quality of life. And so also what I would want to point out is that fatigue is a common one, and pain, and we'll talk about that shortly. Now, speaking of shoulder weakness, problems can occur early on, what we refer to as scapular winging, which means that the shoulder blade is sticking out when people elevate their arms. And that can be asymmetric, like here, or symmetric, as above. And it can limit the range of motion of the shoulders. And sometimes when you stabilize the scapula, the shoulder blade, like here, then the range of motion can increase. So for example, here the scapula sticks out, the shoulder blade sticks out, and that's as far as this individual can lift their arm. And then when you stabilize the shoulder blade, the arm can be raised further up. And that particular, oops, now I'm stuck here. Oops. Huh. Oops, let's see. For some reason, can you still hear me? Because,
Yes.
oh, okay. Yeah, because the slideshow is stuck. Yeah. Oh, okay. Some PowerPoint is not, okay, restart the program, close the program. I might have to close the program real quick and come back because it just got stuck. All right. Let me just see how I can get back here. Give me a second. That is interesting. Okay. Okay. Let's try that again. And sorry about that. We'll go quickly. All right, here. And so I just stopped when I talked about fixating the, stabilizing the shoulder blade and then being able to lift the arms a little bit longer. That particular intervention is used in one strategy to help people, and that's surgical scapular fixation. So that can improve shoulder function in those individuals who gain range of motion with stabilization. But that is really viewed with caution because you have to weigh in the risk of surgery, complications from the surgery, and also weigh in the risk of loss of shoulder mobility. Because if you fix the position of the scapula, you also lose mobility. So that has to be carefully weighed in when making that decision. Other approach to treat shoulder weakness is, of course, and that's going to be a common theme, physical therapy. And some people can also use shoulder braces to stabilize the scapula temporarily. Oftentimes I hear that it's hard to tolerate these braces. So it might only be an option for a short period of time. Now, weakness can also affect the muscles along the chest, like the pectoralis here. This is the muscle up here. And that can cause skin folds, which can either be symmetric, like here, or asymmetric, as shown above. And then I hope this doesn't freeze again. Okay. It's freezing again. I can't believe this. Oh, there we go. Okay. So truncal weakness means weakness of the core muscles. So along the paraspinal muscles that are along the spinal cord, and then, or along the spine, and then muscles of the abdomen. And those can be weak and result in what we call camtocormia, where people have trouble lifting their body upright when walking, or they're lifting up their upper body upright when walking. Some people have to push off from their thighs with their arms to lift them up, or also protuberant abdomen can be a result of this. And when there is such weakness, some people try abdominal binders to help with that weakness. Or when you have trouble lifting your body upright and you develop a lot of back pain with walking, or more fatigue, then high walking sticks or a high walker can be useful. Leg weakness occurs in some, and when there is, usually leg weakness occurs first in the lower leg before it does in the upper leg, but again, there's variability. An ankle brace, when there's foot drop, an ankle brace can help improve mobility, but also prevent falls. And when we asked in the registry, about 18% of people use an ankle brace. And then when there's problems straightening out the knee, an ankle, knee, foot orthosis can be considered. Otherwise, if needed, a walker or cane or assistive devices can be considered. And then about a fifth of people do require a wheelchair at some point in their lives. And when we looked at, when the team here looked at the registry data, they evaluated that people who have a lower number of repeats, so remember what I talked about, the numbers of repeats in FSHD1 can be between 1 and 10. And so if the repeats are lower, in specific between 1 and 3, the risk is higher to require a wheelchair compared to those with a larger number of repeats. Facial weakness is common, as also from data from the registry. It can be asymmetric. It often can be the first symptom. It can impact speech, communication, and eating and drinking. And that's also what we learned when we did the survey among people with FSHD. Problems breathing is still a controversial topic. It's actually not entirely clear how often this affects people. It's still subject of study, but problems breathing is generally considered more rare. It can include sleep apnea or weakness of breathing muscles. And again, we're studying, how frequent this actually is. It's usually considered to be more frequent in people with more severe disease or people with more truncal weakness, so abdominal muscle weakness and the paraspinal muscles. And use of breathing machines like a CPAP or a BiPAP at night differs between studies depending on where you ask the question, but on our registry, about 5% of people with FSHD report that they use a breathing machine at night. Now, what to do about it? It's typically recommended that to get a pulmonary function test when you meet your doctor for the first time, and then periodic testing based on symptoms and based on that result of the first test and based on the clinical impression. In a pulmonary function test, you may be well familiar with that is, but you breathe into a little device and they measure how much air fits into your lungs, how strong your muscles are, inspiratory muscles, so getting the air in, but also expelling the air and getting the air out. Both of these components are being measured. Pain. Pain is really common in people with FSHD, and in our study, 82% of people reported significant pain. So not, just minimal pain or pains here and there, but really pain that impacted their life. And that's consistent with other studies. And the pain most commonly is in the shoulders and in the back, and is most often related to muscle weakness. The pain was reported by all people across the disease severity. So early on, later, it wasn't dependent on how long people had the disease or age. Unfortunately, there is no specific recommendations or strategy, so that can be frustrating. There isn't really a there isn't really a quick fix, but one point is really important, and that's to discuss it thoroughly with a physical therapist, because so again, most of the pain is related to muscle weakness and using other muscles in compensatory fashion. So if you have weakness on one side, you use the other side more, and that can create pain, or asymmetries can create pain. And so it's really important to discuss with the physical therapist, where's the source, what is the potential source of the pain, and is there anything that can be done about it, like, for example, using high walking sticks to give the back a break, etc., or inserts or braces to help with that. And other strategies are really try to maintain the strength you have with staying active, and try different things like aqua therapy. In the water, the strain of the joints is taken away, and the water allows you to be active and use your muscles, but doesn't put as much strain on the joints. And then again, as I mentioned, use of assistive devices, and then eventually, medical management with medications. But again, there isn't really a specific therapy, but it's using the regular things that we use for pain treatment, which includes NSAIDs, but also antidepressants can be used for pain, or anticonvulsants can also be used for pain. And that's really an individual approach, discussing what kind of pain do you have, where is it, and what medications have you tried and tolerated in the past. Exercise, discuss also with your physical therapist, because there is no one exercise training that fits all. It's really an individual approach. But there have been studies on exercise in FSHD, and it's shown to be safe in studies, and has importantly not shown to increase pain in studies. And although I hear from patients that when they're active and doing things the next day, they can feel quite more painful, but then it's really about why is that, and where is the pain, and what's the mechanism of the pain, and can something be done to alleviate that. And maybe the exercise is not the right one. So, but in combination with actually cognitive behavioral therapy, it's been shown that aerobic exercise has shown to increase physical activity levels and also improve social participation. And exercise is important to discuss with your team and with your physical therapist. And in previous decades, there was a time where people with muscular dystrophy were told to sit still and not do too much and not crush their muscles, and that has changed. Certainly, we don't encourage to do bodybuilding weightlifting or so, but certainly aerobic exercise and weights that are appropriate for you, any type of exercise is encouraged and can help. Now, going back to pain, since nearly 88% of people with FSHD report pain, and again in our study 82% that reported significant pain, we wanted to look at how this affects how people experience their disease otherwise. And so we looked at the answers, kind of what problems people have depending on whether they had significant pain in red, or no or minimal pain. And you see all these items that have the little stars next to it here are the items that were significantly more commonly reported by people with pain. And that included, emotional, cognitive things like emotional issues, difficulty thinking, but also mobility, problems with fingers and hands. So there was a difference in how people did depending on whether they had pain or not. Similarly, these is the same kind of data shown, but just how much these symptoms had an impact on people's lives. And so again, you see the blue bar is the people who had significant pain, and the orange are the people who didn't have pain or minimal pain. And again, it shows that the people with significant pain had the fatigue, limitations with mobility and walking, problems with health and emotional issues, and also changed body image due to the disease. Such issues had a greater impact on life in people with significant pain. So less common symptoms that affect other organ systems. So we call them extramuscular, so non-muscle symptoms, are quite a bit more rare, but can involve hearing loss and retinopathy, so a vascular disease of the retina, which is very rare. It's called Coats syndrome. Very rarely it creates symptoms, and usually these hearing loss and the retinopathy in a significant fashion are more common again in people who have the lower repeat number, as I mentioned earlier, the 1 to 3 repeats. And then cardiac arrhythmia has been reported also. And so what's recommended in general is to specifically for people who have symptom onset in childhood or with low number of repeats, to see an ophthalmologist and an audiologist for a hearing test, and a cardiologist specifically if you have symptoms that indicate some problem with the heart or the heart conduction system. Now, research. Let's talk a little bit about what has been done in the past, and I'll have a list here of clinical trials that have been done in the past in the attempt to find a treatment for FSHD. And there, in the 90s, prednisone was trialed, and that didn't have a positive effect. Then several trials have been done with beta adrenergic agonists like albuterol. You may know that medication from people with asthma or COPD. And this didn't show a significant effect, although some other outcome measures had some improvements. So there is some signal in those studies, but nothing really that was convincing. However, this might be revisited in the future, because now, as there are FSHD cell cultures, people have these cell cultures and then they use different drugs and see how that affects DUX4. And one of those adrenergic agonists came up again in one of those screens. So in the dish, there is some evidence that there might be some hope to try this again, but I'm not aware if this is ongoing. But again, that's something that might come up or come across your path in the future. And then there was a drug that was injected to target myostatin, which is an important protein in the muscle. That was terminated because it didn't work, a drug with diltiazem. And then there was a trial that used supplements, vitamin C, vitamin E, zinc gluconate, and selin. And the primary outcome measure, which was walking for 2 minutes, didn't improve, but some of the muscle strength and endurance showed some limited benefit. And then there is an ongoing trial for men with FSHD on testosterone and growth hormone, and we don't have the results of that yet. But we currently conduct a trial, which is now in the open label phase, and you may have heard about this. It's called Redux4 trial. The drug is losmapimod, and that drug was also found when they looked in a dish what drugs can knock down the DUX4 and eliminate DUX4 in the tissue. And so this losmapimod was very promising to have that capacity. And so a trial was carried out in the US and Europe and Canada, and it did not meet the primary goal, which was proving that DUX4 in muscle tissue is knocked down or eliminated. That was the goal. That wasn't met. So in the muscle tissues that was collected from muscle biopsies, that wasn't quite met. However, there were improvements across several measurements. People who received the drug did better compared to people who received the placebo, which didn't have any active drug in it. And so what kind of measurements did they do better in? For example, in ankle strength, people were better, and specifically in range of motion. So, lifting your arms above your head and the shoulder range of motion, what is often referred to as reachable workspace. That's how it's measured. That improved with losmapimod. And so this trial is currently in the open label phase, but and next steps are pending, but we hopefully will learn about this soon, where this is moving to. But you can imagine, as we talked about the genetics, that there are different approaches how to target this disease and to target the root cause of the disease. And you can think about it, well, the methylation is an issue, right? We talked about this, the methyl coding of the sequence. So there are some, theoretical approaches there to increase that and fix the problem at that level, or to eliminate the RNA. So when the DUX4 is already transcribed into RNA, to eliminate that so that it can't be made into DUX4 protein, or to target it here at the protein level and reduce or eliminate the DUX4 protein in the muscle tissue, or going further downstream to target the effects that the DUX4 protein actually has. Although this is also largely still subject to further investigation and study. What are the particular downstream effects of DUX4, for example, early cell death or so, and how to target that. But there's different strategies, and there's different people working on different approaches. And so we will hear more about this in the future. How can you be updated and stay connected to research and be on the front line of what's happening? I do recommend, this is not the most easiest platform to navigate, but I think it's useful. So clinicaltrials.gov. If you type, when you type that into your internet browser, this will pop up, and here you can enter the condition You can enter where you're looking for it, United States or elsewhere or worldwide. And then you can click search. And for example, when I did that, 21 studies came up. And studies can either involve clinical trials where actually an intervention is being tested, or clinical studies, so where no intervention is done, but for example, outcome measures are being tested, or studies that are focused on the mechanism, understanding the mechanism of the disease better, etc. And just clinical trials have to be listed on this website. So there shouldn't be a clinical trial out there in the United States that's not listed here. That's not right. It should be listed here, and usually everyone lists there. The clinical studies, the ones that don't have interventions, not all of them are listed here, but many do nowadays. So this is not a bad way to know what's going on. And then the other way to stay connected with research is to join a registry. For example, the National Registry for FSHD and Myotonic Dystrophy in Rochester here. That way you stay connected, you get newsletters, and oftentimes studies recruit through the registry as well. So you get letters, what's going on, do you have an interest in participating or not? And mainly what you will also see is that a lot we learned from our registry members. So for all of you who are already in it, thank you very much, because everyone fills out a survey once a year, and just we hear back from people how they're doing, how their disease has changed or not, and we learn a lot from this information. And the registry exists since 2001, so a lot of data has already been collected, and that's very useful. And then the FSH Society is another additional resource in addition to the MDA, to stay connected, of course. And why is all of this important? Well, the overarching goal is to find a drug that treats FSHD and changes the lives of your lives and people with FSHD and their families. But there are so many components that are important in that process. And you may think, well, the most important thing is to develop a drug. That's only partly true, because it's a symbiosis between basic science research and clinical research. Because if there is a drug, people will come and say, well, we have a drug, how do we give it, how do we test it in people? How do we know that it's having an effect? What kind of things should we measure? What kind of questions should we ask? What to expect? Is it safe? There's so many questions that occur at the bedside, and we have to prepare for that. And then also if there are many drugs at the same time that need to be tested, who should enroll in which trial? Because you can have a drug that actually works and do the wrong study and not find an effect. So it's a really careful process. So you really have to design and plan it appropriately. And so this is clinical research. And just as there's many more, and you will find it on websites and at your center and ask your local doctor. But I just wanted to mention there is an FSHD research network, and here are the sites in the US listed. So if you live somewhere where you can reach one, there are a couple studies going on that just assess the disease and the disease progression, and help us understand the disease better and prepare for future clinical trials. And with that, I would like to end and thank you for your attention.
Thank you so much for that presentation, Dr. Hummel. That was amazing. We really appreciate your time here today and for your participation in this webinar. I would now like to open this webinar to our attendees for any questions that you may have for Dr. Hummel. Like I had previously mentioned in the beginning of the webinar, if you hover over the bottom of your screen, you will see a Q&A bubble. You can click that bubble and type in your questions. So I'll give it a minute or two for some questions to roll in. All right, looks like we have one. What is the purpose of DUX4? Can you speak to that, Dr. Hummel?
Yeah, oops, I'm still online. Yeah, that's an excellent question, because you wonder, well, if it's supposed to be silenced and tucked away, why is it there in the first place? If it wasn't there, it wouldn't cause problems. So it's not entirely clear, but it seems that DUX4 is important in the developmental stage. So when in the embryo, when things are formed, a lot of other genes are active and transcribed, specifically in muscle development, that later on lose their importance. And so DUX4 plays a role in that early stage. And yeah, and so it can't just be eliminated early on because it's important in the early stage, but later on, it's, as to our knowledge, it's not necessary.
Great, thank you.
And then just another add there. So a lot changes throughout a lifetime, specifically, you know, what genes are transcribed and expressed. So the transcriptomic there's transcriptomic changes throughout a lifetime. What genes are important at what stage in your life, and so DUX4 is part of that. Yeah.
Perfect, thank you. We have another one here. Is FSHD1 and FSHD2 ever mixed within family members? So do you ever see one person with type 1 and a related family member with type 2?
This is an interesting question. I can think of, you know, anecdotally, I can't think of it, but theoretically, yes, because it's two different loci. And you could, for example, have FSHD1 and a mutation on SCHMD1 on top of that. We call this epigenetic because the problem is outside of the FSHD locus. So you could have these two problems at the same time. Yes. But I just wanted to mention also that we learn more about this because oftentimes when genetic testing is done, only one type is looked at. And so FSHD2 is more of a recent discovery. So I'm not sure that a lot of people have been, you know, if it's been evaluated whether type 2 may play a role as in addition. But theoretically, it's possible that it's mixed.
Perfect, thank you. We have another one here. Would you happen to know how many medications are on trial now for the cure of FSH? And in your opinion, what or which is showing the most hope?
Yeah, so the trial that's ongoing now is the Fulcrum, so Fulcrum Therapeutics. They conduct the trial on losmapimod. And that's currently in the open label phase, which means that enrollment has stopped. And so all the people that are enrolled continue on drug in the open label phase. And the results I mentioned earlier that are promising, not as breakthrough, not as a breakthrough promise as we hoped with a primary outcome measure, but promising. And so that will continue. Now, future for losmapimod, I don't know yet. Will there be a phase 3 trial? Possibly, but I can't really say yet because we haven't been updated on that. It's possible that there will be a phase 3 trial. It's, you know, the FDA is involved, so we'll hear more about that, the future of losmapimod. The other trial I know about is the testosterone and the growth hormone, again, which is, I think, closing or basically done the study, and it's only for men. I do not know of other interventional therapeutic trials in the United States as of now, but I know that many people are working on it, many companies are working on it, so I would think that this might change in the next year or two and more opportunities will emerge. And to the other part of the question, generally speaking, a drug that targets the disease mechanism, in my perspective, has the best chance to make a change for people's lives, because we know, and that's the benefit and the importance of knowing the disease mechanism and all the work that went into that. Because if you know the disease mechanism, if you know the root cause, you can target it directly and very specifically, limiting, you know, off side effects, limiting, oops, sorry. And really targeting the root cause. This is different than when you're sort of more fishing in the blind and you treat symptoms, but they're not really mechanistically related. Or, it's always, you can treat, there's always symptomatic treatment and disease modifying treatments, those two groups. Symptomatic treatment is usually a treatment that helps relieve symptoms like Tylenol for a headache, while disease modifying treatment is really a treatment that changes the disease progression. And that's obviously what we want. Of course, we like to relieve symptoms, but our overarching goal is really to make a change. And that, I think, the disease mechanism targeting treatments have probably the best potential to provide that.
Thank you so much. We have another one here. You mentioned arrhythmias as a possible symptom. Do you know which specific arrhythmia people with FSHD could experience?
Yeah, so there have been reports on atrial arrhythmias, for example, or atrial fibrillation, and so it's really the conduction system that's affected. But it's difficult because it's not a common thing. It's also something that occurs in the general population and people without FSHD. Sorry about that. But basically the atrial arrhythmia, so really, so the test to do is an EKG, and if there are any abnormalities, then follow up with a cardiologist.
Great, thank you.
Then, yeah. So then there, yeah.
Oh, go ahead. Go ahead.
No, you go ahead.
We have another one here. With the mRNA technology progressing so fast in the past year, for example, with the vaccines, could this possibly lead to potential use on DUX4 and its transcribing?
Sorry, I'm getting a constant call here. DUX4, maybe. I think that the RNA technology certainly has made a lot of progress. I think that also the other no, I'm still on the other potential. So the RNA targeting treatments have made a lot of progress, and the other thing that you've heard about probably is antisense oligonucleotide therapies, where drugs go in and bind to the mutant RNA and then eliminate it by binding to it. And so that's another strategy that's being pursued. Yes, so targeting it at the RNA level, I think has a potential.
Awesome, thank you.
And I think one benefit to that also, one benefit is there's always trouble if the gene product or the protein is necessary. So you can't knock down something that you need at certain levels. So the one, DUX4 is tolerated if it's silenced. That's the normal healthy stage. So that's kind of in favor of that strategy as well. Yep.
Thank you. We have another one here. Can dysphagia and respiratory issues occur even when the disease is not severe?
Yeah, I mean, that's always the issue, that there's so much disease variability, and the answer to that is yes, because people, and so there is great variability, and we don't entirely understand the variability sufficiently. So one aspect I mentioned is that the repeat length has some predictive quality. So, lower repeat numbers, 1 to 3, usually earlier onset, more severe disease compared to larger repeats. But in general speaking, a lot of the predictors of disease severity, we don't know yet. And there might be, you've learned now that there is an epigenetic factor, for example, the SMCHD1 gene that, causes an effect on the FSHD gene. And there might be others that genetic modifiers that modify how people experience the disease, either in terms of severity or in terms of what tissue, what areas of the body are affected at what age. And we haven't learned about these yet, but part of these studies that are ongoing is to learn more about that. And if you know that, you can also modifiers that modify the disease could also be potential treatment targets. So it's not just about gaining knowledge, it's also the end goal is always to think about treatment avenues or approaches.
Thank you so much. We have another one here. Have you had any FSHD patients report any adverse events from receiving the COVID-19 injection?
That's a good question, and I don't know if I'm the best person to answer that question. To my knowledge, no.
Thank you. Another one here asks if you know any updates with research and CRISPR.
Yeah, CRISPR is always on the mind and out there. There are teams working on that. But I don't think, to my knowledge, there isn't anything close to really reach the patient yet.
Great, thank you. There's another one here. Would you happen to know how would losmapimod help with fatigue?
This is how did losmapimod help with my fatigue? So that indicates that you may have been a participant in the trial, which thank you if you did. But basically, fatigue is sometimes challenging because fatigue can be so many things. Fatigue can be from just tired, sleepiness, not getting enough sleep, or fatigue can be actually from the muscle. So muscle fatigue, and fatigue is very common in people with muscular dystrophy. So speaking of the muscle fatigue, not so much the other fatigue, I can easily imagine why losmapimod could have done that, because it has effects from what we saw in the preliminary data that was shared with us. It has effects on muscle strength, it has effects on muscle function, and so improving muscle function and muscle strength should also improve muscle fatigue. And so I could see why that is the case. But yeah, and losmapimod works directly on reducing the DUX4 levels.
Perfect, thank you. Looks like we have time for about one or two more questions. So we have one more coming in here. Do you ever see people with FSHD1 and limb girdle?
That's also a great question. So there's two parts to this question's answer. So first, yes, of course, you can always have two diseases at the same time. It's very rare because both of these diseases are rare, so chances are low, but of course it's possible. What we have seen, and we looked at this also, and is that some people get falsely diagnosed with FSHD and in fact have limb-girdle muscular dystrophy. So it's, as you know, the genetics are complicated in FSHD, and sometimes they require expert interpretation, and sometimes they require different types of tests. For example, there is no one genetic test that measures the repeat length and the methylation level, for example. There is no one genetic test that measures FSHD1 and FSHD2. So there's different parts to that. So a doctor has to follow more of an algorithm and think through, if one comes back indeterminate, to go to the next step to really arrive at a definitive answer. So it can be complex. So first question is, does the patient really have two diseases, or is it one disease and the other one was falsely diagnosed? There are always hints to one or the other that can be sorted out with a physician. For example, a lot of the limb-girdle muscular dystrophy can have symptoms like FSHD, involving the shoulders, involving the legs, etc. So it can be sort of mimicking each other. And so it's important to kind of look at aspects that might argue for one or the other, and then really follow up with genetic testing and detailed genetic testing. And that can be not just one test, but sometimes a series of tests.
Perfect. Thank you so much, Dr. Hummel. So it looks like that is all the time today that we have for questions for Dr. Hummel. If you do have a question that was not answered, please feel free to reach out to the MDA Engage email address at mdaengage@mdausa.org. I really want to take some time to appreciate Dr. Hamel. We really appreciate your time and your expertise and everything that you do for the neuromuscular community.
Thank you all for joining.
This concludes our webinar for today. Again, I want to thank Dr. Hamel for her time today and our supporters at Fulcrum Therapeutics. We would love to hear your comments about this webinar. If you have a smartphone, you can open your camera and point it to the QR code on the screen shown here. A web page will pop up with a short survey on today's webinar. If you do not have a smartphone, once the webinar is over, a screen will pop up with the survey as well. Again, if anyone has questions about this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with FSHD, FSH, or a loved one of someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This concludes today's MDA Engage webinar on facioscapulohumeral muscular dystrophy.